outline of my presentation is we will see lower limb venous system and flow mechanism, understanding of venous waveform nomenclatures, normal physiological and abnormal pathophysiological changes, Doppler evaluation of lower limb veins, anatomy and basic approach, Doppler evaluation of common lower limb pathologies as well, and some common examples of painful swelling, non-vascular causes. So as we all know, lower limb venous system includes basically superficial venous system, which is lying or spread around within the superficial fascia and superficial planes and drain most of the part. And another important is the deep venous system, which is lying deep to the deep fascia within the intermuscular planes, and it is all running along with the arterial system as well. There are important intercommunicating channels which are known as perforator veins. So these all three are important, important parts of venous system of the lower limb. Now, blood flow mechanism is from distal to proximal, from the distalmost part towards the center, that is towards the heart, because veins has to drain from periphery to center. And the blood flow from superficial venous system to the deep venous system. And soleal pump or soleus muscle pump or calf muscle pump is a very important mechanism contributing in systematic and spontaneous blood flow towards heart. And another important structures, these are venous valves, which are there within the veins, which provide unidirectional blood flow and prevent the reverse or the retrograde flow by coapting with each other. And this is how the unidirectional blood flow in the venous system is maintained. Any abnormality within these valves will lead to abnormalities or various pathologies, leading to venous incompetence or venous insufficiency. So this is what the summary of consensus statement by Vascular Society of Medicine and Radiological Society of Vascular Ultrasound. This is a very good article produced by Kim et al. In the Vascular Medicine Journal, and they suggest certain measured descriptors and modified terms to be utilized while we are describing or while we are evaluating the vascular systems, whether it is artery or it is a venous system. So there are certain measured descriptors and certain modified terms. In venous waveform nomenclature, we do have measured descriptors as first indicators of the flow direction descriptor, another is flow pattern and spontaneity of the flow. Flow direction, which indicates antegrade flow. Antegrade flow means the flow normal direction of the blood flow, that is from distal to the proximal direction, or the flow is in the reverse direction, that is the retrograde from proximal to distal, or flow is absent. Flow pattern can be showing some phagicity, which is very important. Phagicity is respirophagicity, because the mechanism of respiration involves pressure changes within the thoracic cavity as well as in the abdominal cavity, and leading to some changes within the flow pattern of the venous system. Or flow can be pulsatile, or flow can be continuous without any phagicity or any pulsation, or it can be regurgitant or going regurgitating and going showing reflux within the cycle. Normally the flow is showing spontaneity. There is spontaneous flow. Without any effort, the venous flow is showing unidirectional from distal to peripheral flow. And if it is not showing spontaneity, means it is non-spontaneous flow. So these are direction, pattern, and spontaneity are the major descriptors with all these points. Modified terms are augmentation, reflux, and fistula flow. Augmentation means when we are examining venous system, we see there is flow is spontaneous, so we see sometime we need to augment the flow to see the status of the luminal status of the, the vascular channel by distal compression of the leg or whatever extremity we are examining. So particularly in leg, there is calf compression leads to augmentation of the flow in femoropopliteal venous segment. So augmentation can be normal or it can be reduced in certain pathology or it may be absent. Reflux means there is abnormality in the flow direction and there is reflux of the blood flow while performing certain maneuvers. And when there is abnormal communication between the artery and the venous system or the artery and the vein, there is a communicating channel where we see a continuous low resistance, high velocity flow, which is known as a fistula flow. So these are modified terms. Now, let us understand by the spectral patterns. So direction, this is the normal antegrade direction when the vein is showing flow from proximal to distal away from the probe blue direction. This is below baseline. It is a normal antegrade flow towards heart. When there is retrograde, the flow is towards the probe above the baseline. When there is no flow, we cannot elicit spectral waveform. Now, respirophasic flow, we may see certain decrease in the flow velocity and increase and decrease because of the pressure changes within the abdomen on inspiration and expiration. When there is inspiration, the intra-abdominal pressure rises, there is flow reduction is there. And when in expiration, there is flow increase there. And reverse is there in the thoracic and upper, upper limb vessels and upper central vessels. So this is the normal respirophagicity or respiratory phagicytic effect. It is decreased when there is subtle undulations are present, no major phagicity is seen, it is decreased in certain conditions. This is the type of spectrum. When flow becomes more pulsatile, it shows pulsations which are basically the pressure changes or the transmission of pressure changes from the right side of the heart, that is the atrial pressure changes. So this is how we see pulsatile flow. When the flow is not showing any kind of pulsation, it is a continuous unwavering spectrum. And when there is a forward flow integrate and the reverse component is there, it is a regurgitant flow. So this is how we understand these major descriptors of respirophagicity and pulsatility. Another is spontaneity. When we examine venous channels, when we examine lower limb veins, we usually see there is spontaneous, continuous forward flow is there with certain undulations of respirophagic effect or certain pulsations are there. So this is a spontaneous. But in certain situations or sometime, we may not be in position to see flow in spontaneity. So we need to augment to see the flow. We need to augment by certain maneuvers, by distal limb or distal extremity muscle compression. So when the flow is non-spontaneous, we will not see the spontaneous flow and we need to observe compression and maneuver and we see the flow is there. Now augmentation, another modified term is augmentation. When we press distal vascular channel or distal vessel, distal vein, we see sudden increase in the blood flow. And this is known as augmentation. And augmentation indicates that there is the distal or the downstream channel is patent right from the area of compression to the site of insonation. And there are certain undulations of velocity are also there when we ask the patient to perform Valsalva. There is a subtle increase and followed by no flow because of the Valsalva maneuver. And again, when we release, there is again the restoration of the blood flow is there. So there is normal augmentation, there can be reduced augmentation, and there can be no augmentation or absent augmentation when there is obstruction between the site of insonation and the calf compression. Another modified term is reflux and fistula flow. When we ask the patient to perform Valsalva maneuver, we will see there is abrupt reversal with slightly increased vascularity and then gradual reverse flow and in the entirety for a couple of seconds or even significant time duration. This is indicative of reflux within the vein. And as at the site of arteriovenous fistula, we will see continuous, low resistance, high velocity, high volume flow. Now, physiological variations are there in certain physiological states in the peripheral venous waveforms. In the lower extremity, we can see normal respirophagicity with the exhalation and inhalation. In inhalation or inspiration, there is increased abdominal pressure, there is no flow because of the increased intra-abdominal pressure, and then in expiration, there is spontaneous flow. And in upper extremity, we can also see slight respiratory phagicity, particularly in the proximal vessels. Now, physiological state of normal peripheral waveform in form of pulsatility, the central veins like internal jugular, subclavian, axillary, and IVC veins show normal pulsatile nature in the spectrum, and it is because of the transmission of the pressure changes within the right side of the heart. And the proximal abdominal IVC sometimes also show some pulsatility characters. So these are all physiological states in which we can see these changes. Now, certain pathophysiological states with certain explanations. The continuous flow is seen with a steady velocity without any phagicity. It indicates more central obstruction proximal to the site of insonation or examination. Suppose we are examining femoral vein and we see this type of spectrum, the femoral vein, which means proximal to femoral vein, that is in the iliac segment or in the IVC, there is some obstruction is there. When the flow is pulsatile in the femoral vein, it is an abnormal finding in lower extremity when there is elevated central venous pressure. There are certain conditions in which we can see this type of pulsatile pattern in right-sided heart failure, tricuspid valve regurgitation, pulmonary hypertension, and any condition causing right-sided increased elevated pressure or dysfunction. Now, regurgitant flow, again seen in situations where there is increase in the right atrial pressure, creating a form of flow pattern similar in antegrade and retrograde components. Unlike pulsatile flow, where the intensity of the retrograde component is far less than the antegrade component. Now, in reflux, we can see it is because of the abnormality of the valve. So, which may be because of the abnormal valve or abnormal venous distension leading to incomplete closure of the valve, or the valve is totally damaged. It remains open. So, whenever we perform any Valsalva maneuver, there is significant reflux in the vein at the site of examination. Now, coming to another important part is anatomy in basic approach. One must be very well known to the anatomy of the lower limb arterial deep venous system as well as the superficial venous system. I will not much go in detail of these anatomies because it is all well known to everyone. So this is how we can see the external iliac vein continuous as common femoral vein at the level of iliac inguinal ligament, and then just caudal to it divides into deep femoral vein which supplies the thigh, which drains the thigh and then continuous as femoral vein. And in the popliteal fossa and posterior to knee, we see the popliteal vein. And in the anterior compartment, we see anterior tibial, posterior. In the medial compartment, we see posterior tibial and peroneal veins. As far as the superficial veins are concerned, basically, great saphenous vein is formed by the dorsal venous arch, its medial part, just anterior to the medial malleolus, and it is continuous ascending in the leg. It receives two tributaries, anterior arch vein and posterior arch vein, and then it is continuous medial aspect of the knee to the thigh, and it joins the femoral vein, common femoral vein, just below the inguinal ligament, and it receives certain tributaries, very important tributaries, and then join the deep system, that is the common femoral vein, through its terminal valve. And posteriorly, on the lateral aspect of the lateral arch of the dorsal foot, continuous posterior to the medial malleolus as short saphenous vein, small saphenous vein, which basically joins the popliteal vein through the saphenopopliteal junction. The joining of the small saphenous vein to the popliteal vein, there are a lot of anatomic variations are present. It can join high up, or it may join with a small tributary and then continuous as vein of Giacometti, which joins again the great saphenous vein. There are certain perforator veins which are there in the along the entire superficial venous system, and they drain into the corresponding deep veins. These are the lower leg or the above ankle perforators. These are 3 in number. Their number and location can be slightly variable. So these are the lower leg, medial leg perforators, or we can call them Cockett's perforators. Then in the upper leg or just below the knee, we have anterior and medial perforators, which are known as Boyd's. These joins anterior arch vein and the posterior tibial vein and drain there. Another important is the DOD, or the lower thigh perforator, which is there in the adductor canal, and it joins the great saphenous vein with the superficial femoral vein in the thigh. And we can have in upper thigh another anterior perforator. So these are the perforators. We can also see some posterior perforators which drain the superficial system to the small saphenous vein. And sometimes we see lateral perforators also, which drains basically lateral part of the leg to the peroneal veins. So this is how we understand the basic anatomy of the venous system. So important landmarks, there is venous system lies in the superficial fascia. These are the cutaneous or the dermal branches. Then the reticular veins lie just deep to the dermis within the superficial part of the superficial fascia. They join to form and drain into the main superficial veins, which are these 2 important veins, that is great saphenous and small saphenous veins, which lies basically in the sheath of the superficial and deep fascia. And then these veins drain to the deep venous system via indirect perforators, which we have already seen. There can be chances of reticular vein directly join the deep vein through the direct perforating vein. And saphenofemoral junction tributaries are very important as far as the insufficiency is concerned. The great saphenous vein receives tributaries from anterior thighs, accessory anterior saphenous vein, posterior accessory saphenous vein, and another is superficial external pudendal vein, which is draining from the pudendal area, and superficial inferior epigastric vein and the superficial circumflex, which is draining the basically inguinal and upper thigh area, and all drain into the great saphenous vein, which in turn drain into the femoral vein through the terminal valve. So let us have some idea of general considerations. So anatomy should be well known before examination. Anatomy variations may exist. Veins lack in muscle layer in their walls, so they are very compressible. So we need to put a gentle pressure while examination the superficial veins. Normal flow is directed from distal to proximal in the superficial and from superficial to deep venous system. When we see sluggish or slow flow, we can see flow on real-time beam mode imaging as echogenic flow. And deep veins always accompany arteries and usually paired in the leg in form of veni comittantes. And perforator should be named as per their location in thigh, knee, leg, and ankle, anterior, posterior, and lateral lesions. Now coming to a bit about technical approach, patients in examination of the lower limb, patient normally examined in supine, semi-flower, or standing position when we are to evaluate for insufficiency and varicose veins. We can apply decubitus approach as and when needed. We can see in sitting position with the legs hanging aside as comfortable to you, because we need to distend the veins for proper evaluation. Probe selection, definitely curvilinear probe is used for abdominal approach to see the IVC and iliac veins, and for obese legs. And we can use high resolution linear probe 3 to 12 or 16 megahertz, whatever available to you with your equipment for superficial venous system. It is important to optimize the Doppler settings for veins, particularly for slow flow with low, filter setting, wall filter setting, and the gains of the accordingly. So we have to see the proper settings of the venous system. We examine from proximal to distal because the proximal veins are larger in caliber. So it is very easy to examine, and this is how we normally examine. We examine every segment of the vein in transverse plane and in longitudinal plane with graded compression to see the compressive ability of the vein. We analyze the vein in B mode by we can see its wall, its perivascular area, its lumen, and is there any intraluminal content is there or not. Then we examine on color to see the flow signals and to characterize the spectrum through pulse wave Doppler. We begin at inguinal region, and if we find any abnormality, any like thrombosis or wall thickening or irregularity within the common femoral vein, then we extend our examination more proximally. We go back and see the IVC and examine the iliac segment also. Certain maneuvers we have to apply, like compression to see the compressibility of the veins, Valsalva to see any reflux in the veins, and then distal leg compression to see the augmentation in the vein. So again, we have to see for compressibility, flow signals, their direction, respirophagicity, augmentation, distal compression, and on Valsalva, reflex on Valsalva, in every segment of the vein. And we should also evaluate the perforator veins in the medial thigh and leg. These are very important perforators. And we examine the patient in erect or reverse Trendelenburg position for superficial venous system insufficiency. So these are technical, points, and how do we approach. So for deep venous system, we start our examination in groin. If we see any abnormality in the common femoral vein, then we restart our examination for the IVC and iliac segments. Then we see the compressibility, flow signals, augmentation, and Valsalva reversal. Then we see its division in the deep femoral and the superficial femoral veins. And then in the mid-calf, mid-thigh, we see the superficial femoral vein. And then popliteal vein is examined in popliteal fossa in slightly lateral, position, and we see the popliteal vein and then the posterior veins. For anterior tibial vein, we see the anterior compartment and trace the vein in entirety. For superficial veins, we begin our examination at the saphenofemoral junction at just below the inguinal region. Then we examine its tributaries, and then we see its anterior and posterior accessory veins, and then we see the great saphenous vein in entirety up to knee level, and then in the lower leg or in the leg region. Then we see the small saphenous vein, saphenopopliteal junction. Then we see in the posterior calf and in its entirety up to lateral malleolus. So on B mode, we can see the wall which is smooth and thin. Lumen is clear compressible. No perivenous abnormality. When any abnormality in the vein is there, it can be thickening of the wall, irregularity in the wall. There can be echogenic or calcific intraluminal content, or wall can be showing calcifications. Lumen may show intraluminal material and it becomes non-compressible when it is showing thrombosis. Or in post-thrombotic syndromes, we may see narrowed, lumen and atretic segments. There can be perivenous echogenic thickening in cases of superficial thrombophlebitis or when there is acute phlebothrombosis. There can be abnormally dilated and tortuous veins in case of varicose veins. So this is how we see the groin, Mickey Mouse sign, and we completely compress the femoral vein, common femoral vein, and the great saphenous vein at its saphenofemoral junction level. It is compressible. Then the great saphenous vein can be seen in the upper thigh as a saphenous eye sign or a Egyptian eye. There are two sleeves of the fascia, deep fascia and the superficial fascia. It is lying here. We can see by compression and on color Doppler as well. Then coming to the common femoral vein examination, we see the respiratory phagicity, record it. Then we compress the cuff, see the augmentation, which is seen as an abrupt increase in the antegrade flow. Then we see the Valsalva maneuver to see any reflux in the common femoral, the deep venous system. So we ask the patient to perform Valsalva. There is reduction, there is reflux, trivial reflux, and there is no flow, forward flow. This indicates competence of the vein at the site of examination and proximal to it. Similarly, we can see the competency of the saphenofemoral junction on Valsalva. There is normal antegrade flow. When we ask the patient to perform Valsalva, there is no reversal, no flow signals on color Doppler evaluation. We can see on spectrum also, when we perform spectral Doppler analysis, we see abrupt reversal and there is no flow reversal component at the saphenofemoral junction just proximal to this terminal valve. Intravenous valve can also be seen on real time, and we can see the flow passing through it. This is how these are, the cusp of the valve is seen with small slight dilatation just at the level of the venous valves. This is the normal variation. Then we proceed to see the femoral vein in thigh. We compress it, we see the flow and perform Valsalva, we see augmentation as well. Then we see to the popliteal vein, we compress, we see compressibility, we see the normal flow signals. And similarly, we can see that leg veins and veni committantis with the flow signal present in compression and distal augmentation. Now, common pathologies can be deep vein thrombosis or thrombophlebitis, acute or chronic, venous insufficiency, and varicose vein. These are three important pathologies. Deep vein thrombosis includes basically formation of blood clot or thrombus within the venous system or within the vein. The pathophysiology is Burko's triad when there is abnormal venous stasis or sluggishness of the flow because of any reason, or there can be endothelial injury in form of trauma or any other form, chemical injury or physical injury or traumatic injury leading to provocation of thrombus formation. And another third component is hypercoagulability of the blood. Its complications are distal embolization, that is the pulmonary embolism, and post-thrombotic syndromes. On ultrasound, what we can see on deep vein thrombosis, there can be venous distension, lack of compressibility. The vein will not be compressible, absence of color or spectral signals, visualization of intraluminal abnormal thrombus. Acute thrombus is usually hypoechoic. It appears hypoechoic, and chronic thrombus can be seen as echogenic, and then there can be retraction of the thrombus in variable edges and wall thickening, and the lumen diameter will be reduced in cases of chronic DVT. We can see flow abnormalities in form of continuous flow, loss of hegicity, reduced or absent augmentation on calf compression, and presence of collateral flow so as to establish the normalcy of the flow. So we always see the proximal collaterals proximal to the obstruction, which is basically when deep vein thrombus is there, the flow goes to the superficial system through the perforator veins, and the superficial vein drain into the more proximal segment. So this is a case where we can see on color Doppler loss of no color flow signals in the common femoral vein with the venous flow setting. It appears hypoechoic, distended, non-compressible. And this is in acute stage, we can see hypoechoic thrombus. Sometimes we can see slightly in subacute stage, or this is another example in the venous system, we can see echogenic thrombus. And it is important to see the proximal extension and limit or edge of the thrombus. So this is how we see the proximal edge of the thrombus, which is very dangerous, And when the clot retraction starts after treatment or after due course of time, we can see there is shrinkage, there is retraction, and the flow is established, and the wall becomes thick, and the thrombus is echogenic. In acute thrombophlebitis, we can see non-compressible vein with perivenous echogenicity. Some vascularity is increased, wall become more thick, hypoechoic thrombus, non-compressible, no color flow signals, no augmentation, no flow signals. We call it thrombophlebitis because the wall is perivenous echogenic thickening is there, and even we can see very increased mural and perimural flow on microvascular imaging. And it is non-compressible, and it shows slightly hard intraluminal thrombus. So these are all salient features of acute thrombophlebitis. Now in chronic, when there is in due course of time or in after treatment, we see there is clot retraction and the luminal flow is established, but there is irregular retraction, and we can see irregular web-like areas attached to the wall and within the lumen, forming a web-like area with irregular wall thickening with patent lumen is suggestive of focal fibrotic thrombi. And sometimes we can see even the calcifications within the chronic thrombi, as we can see in this case. So this is how we perform compression, very gentle compression. Both the veins are easily compressible, where in this case of thrombophlebitis, even the vein is not compressible. It indicates the thrombosis. So in thrombosis of vein, we can see thrombophlebitic changes. We have to search for proximal edge and total thrombic load. For tibial vein, we see flow. And when there is tibial venous, anterior posterior tibial venous flow, we cannot see. These are not compressible. These are hypoechoic distended veins, venicomitantes of the leg. And even sometimes we can see single territory or single comitante is thrombosed and another is showing blood flow in it. So this is how we have to trace each and every segment of the veins. So this is a case of superficial thrombophlebitis. Now another case, female 18 years with painful swollen right lower limb. At the groin region, femoral vein is hypoechoic distended great saphenous vein, non-compressible, no color flow signals. Then we need to examine the proximal segment. IVC is all right. The thrombus is extending into the external iliac vein with the proximal limit. This is the thrombic case, proximal edge. It is very dangerous. This can dislodge and put pulmonary embolism. So this is the ideal case for IVC filter placement. So this is how we see the proximal extent of the thrombus. The femoral vein, and it is also involving thrombosis is also seen at saphenofemoral junction and great saphenous vein. The thrombus extension should be thoroughly examined in its entire segment. It is extending to involve popliteal vein also. There was extensive thrombic burden in this patient, right from the leg, calf to the superficial femoral and in the external iliac, with involvement of the superficial venous system like long great saphenous vein. Another case, 40-year female with, it is follow-up case of the right lower limb DVT under treatment. So there is slightly echogenic thrombus is present within the femoral vein. However, some signals of the blood flow are also present. There is slight retraction of the thrombus. There is flow is establishing. So we can see, we proceed proximally to see the iliac veins. The iliac veins are also seen showing thrombosis with some flow signals. IVC is normal. So the flow is, so thrombus is in femoral and extending proximal into the iliac segment. IVC is spared. Saphenofemoral junction is competent, normal, showing normal flow. Now common femoral vein showing partial flow, which shows this is continuous type of flow without any phagicity, or there was no any augmentation, very subtle augmentation. This indicates proximal obstruction, as we have seen the iliac vessels are also, iliac veins are also involved. Augmentation is not present means more proximal obstruction is there. It is because of the obstruction or thrombosis of the superficial femoral vein or the popliteal vein. So the superficial femoral is also showing partial flow with thrombi, and popliteal vein is showing thrombosis. So the patient is under treatment. Some recanalization has happened, but there are significant thrombic burden at this time of examination also. So it is a case of recent DVT under treatment, right lower limb with partial femoral recanalization. Another example, 6-year female, 6-year, my right groin and thigh painful swelling, suddenly developed chest pain and hemoptysis. The patient was asked for lower limb venous doppler. I can see the femoral vein is showing in this child echogenic thrombus. It is distended, non-compressible, no flow signals. Saphenofemoral junction is also thrombosed. Popliteal vein is all right, with augmentation in the popliteal vein through the distal leg. But on examination of the chest, I simultaneously examined the patient's chest. I can see on one side, right side, there is little amount of fluid with basal atelectasis and some peripherally sitting subpleural hypoechoic areas within the lung, suggestive of infarcts, pulmonary infarcts due to pulmonary emboli. Now another example, female 40-year. It is also follow-up case of popliteal vein thrombosis under treatment. So let us see the popliteal vein. On B mode, we can see the vein is slightly compressible, but it shows intraluminal web-like appearance and echogenic fibrotic thrombi still present. On Valsalva, we can see normal flow. In Valsalva, we can see gross reflux. Again, normal flow. On Valsalva, we can see this is normal flow. On Valsalva, we can see significant reversal of the flow. So this vein, the deep vein, that is the popliteal vein, has become insufficient or incompetent because of the process of thrombosis, showing deep venous or popliteal incompetence. So it is sequelae of chronic DVT in form of fibrotic plaques or fibrotic thrombi with incompetence of the popliteal vein. The same case. Now coming to another pathology, that is the venous insufficiency and varicose veins. We understand these both conditions simultaneously. So venous insufficiency, when veins of the legs are unable to return the blood to the heart. Pathophysiology includes venous valve dysfunction, which causes reflux, ultimately leading to venous hypertension in the proximal segment, venous distension, endothelial and damage and dysfunction, and capillary dysfunction, leading to increased hydrostatic pressure, edema in the soft tissue around, hypoxia, and tissue damage. So these are all sequential events in cases of venous insufficiency. Now, clinical symptoms can be swelling of the limb, pain and heaviness in the limb, development of varicose veins, skin changes in form of pigmentation, thickening, and development of venous ulcer on trivial trauma and which are very poorly healing. So these are all clinical symptoms in case of venous insufficiency. Now coming to varicose veins, these are basically abnormally dilated, elongated, and tortuous superficial veins in the leg region. And the important cause is venous valve dysfunction or incompetence. Valve dysfunction can be congenital as a result of congenital defect or some acquired pathologies causing damage to the valves, likely trauma, history of thrombosis, history of inflammation, age-related degeneration. Again, clinical symptoms include swelling, pain and heaviness in the lower limb, development of the varicose veins, again leading to skin changes, hyperpigmentation, eczema, and venous ulcers because of increased venous hydrostatic pressure or venous hypertension. Now, at ultrasound, what we can see on varicose veins and venous insufficiency? We can see presence of venous reflux on valsalva in the affected vein. We can see valve abnormality in form of incompetence and development of retrograde flow through the valves in real time. Dilatation of the veins, tortuosity, and development of varicose veins in the superficial venous system. We can see on augmentation, the augmentation can be reduced and it is followed by reflux because of the incompetence of the proximal valves. And another flow abnormality can be non-phasic or continuous. There can be presence of thrombus or no thrombus, skin and soft tissue thickening. So these are all what we see on ultrasound. So this is how we see the intravenous valvular incompetence with reflux when we perform Valsalva and we examine the particular vein. Let us take this example and this valve. This is the normal flow on B mode. On Valsalva, there is gross reflux on B mode. We can see the echogenic blood flow through the valve and there is development of incompetence, significant incompetence. This is the normal, this is abnormal flow through this valve. So this is how we assess the abnormality and incompetence of the valve on B mode as well as on color Doppler. So deep veins, like in this case, we examine femoral vein and then we ask the patient to perform Valsalva. If we see significant reversal, it indicates deep venous insufficiency. As we can see in this case, the femoral vein, common femoral vein is showing significant reversal on Valsalva. Now coming to examine the saphenofemoral junction incompetence and great saphenous venous insufficiency. Let us take this example. This is saphenofemoral junction. This is the normal direction of the flow. In Valsalva, we see the reversal, significant time reversal. When we perform spectral analysis, we see significant flow reversal. Then we come to the great saphenous vein. This is the normal antegrade flow. This is normal antegrade flow. And this is the flow reversal on Valsalva in the, great saphenous vein. This indicates incompetent saphenofemoral junction and insufficiency of the great saphenous vein. Now let us take this example of again incompetence of the well. I am examining perforator. On B mode we can see to and fro movement of the blood, significant reversal on B mode. There is reversal of the flow through the perforator. See another perforator which is dilated. This is the normal. There is to and fro flow. This is the normal flow. Again, in the last, when I compress the cuff, there is significant flow reversal, and this is again re-establishment of the normal flow. So this indicates these perforators are abnormal and showing incompetence. Varicose veins can be seen as multiple dilated venous channels, distended veins. They can be tortuous, significantly tortuous, forming a mass. On color Doppler, we can see flow and reversal flow in them on Valsalva. So these are all variable appearances on B mode in cases of varicose veins in the leg. Now this is a male 30-year showing obvious varicosities in the upper, in the thigh anteromedial aspect. The femoral vein showing blood flow compressibility. Normal physicity in the femoral vein, augmentation is normal. Coming to the saphenofemoral junction, this is the normal flow, and on Valsalva we see significant reversal, which is seen as a color flow, red color. And on spectrum we can see significant reversal. So we can see saphenofemoral junction is incompetent, number one. On coming down to the great saphenous vein, when it receives its tributary anterior accessory saphenous vein, which is dilated as compared to the great saphenous vein, which this great saphenous vein in thigh appears competent. But this appears incompetent and insufficient. The flow is basically received by the incompetent accessory saphenous vein, which is showing a reversal. Anterior accessory saphenous vein showing marked reversal on Valsalva. Multiple anterior thigh varicose veins, as we have seen in the photograph. Blood flow and reversal. Multiple anterior thigh varicoceles. And again, there was a entry point in the lower thigh. We can see a communicating channel from these superficial varicose veins, again joining the great saphenous vein just above the knee joint. This is the entry point, and this is the exit from its communication with the great saphenous vein. This is incompetent and forming a varicosities, developing the varicosities within this territory only. So in this case, basically, this is the anterior accessory vein is incompetent, and this is again entry point, which is joining the great saphenous vein, and rest of the venous system appears normal. So this is how we see the entry and exit point and the segment of the affected vein, which is showing insufficiency and incompetence. Now another case. Male 30-year with leg pigmentation and poorly healing lower leg ulcer. So there was a history of non-healing ulcer, pigmentation. So supposed to be a case of venous insufficiency. Saphenofemoral junction on right side appears to be incompetent with reversal of flow. Great saphenous vein is showing reversal on Valsalva. Basically, I have mentioned this is on Valsalva. Now see the same case in the popliteal venous segment. We can see what is there in the deep venous system. This is the normal antegrade flow in the popliteal vein. When we ask the patient to perform Valsalva, there is significant reversal in the popliteal vein also. So there is ulcer popliteal venous incompetence, multiple varicosities adjacent to the ulcer, and a dilated posterolateral incompetent perforator in this case. So basically, there is deep venous insufficiency in this patient, saphenofemoral junction incompetence, great saphenous venous insufficiency, associated leg varices, and lower leg incompetent posterolateral perforator, along with soft tissue thickening around the ulcer. So these are all findings within this case. Now another case, 48-year female, painful nodular swelling in the right leg. Painful nodular swelling. So this is how the venous wall is incompetent of the femoral region. Incompetence. In the region of the nodular thickening, nodular swelling, we can see multiple dilated tortuous veins with thrombi within them. So thrombosed varicose veins with incompetence of the saphenofemoral junction, and we can also see the reversal of the flow within the great saphenous vein with venous insufficiency in the great saphenous vein. So this is how we can see the nodular swelling, the tortuous veins with changes of inflammation and phlebitis and thrombosis. So these are basically thrombophlebitis of the varicose veins along with saphenofemoral junction and great saphenous venous insufficiency. Now this is a follow-up case of chronic DVT with pubic swelling. Patient is having a suprapubic and swelling in the pubic area. Now I can see the web-like intraluminal filling defect within the common femoral vein, which indicates chronic DVT. There is insufficiency of the common femoral vein. We can see reversal of the flow on Valsalva on color. We can see saphenofemoral junction incompetence. We can see GSV is normal, but here we can see the flow is directed to the suprapubic, that is a pudendal vein, and forming varix on the pubic area. So this is basically chronic DVT with femoral and saphenofemoral junction incompetence with pudendal varicose. This appears to be like a mimic of varicose veins, but it is a soft tissue mass with hypoechoic echo texture along the great saphenous vein. It shows multiple vessels. So these are not varicose. This is basically a vascular malformation or hemangioma in the lower leg. Now, a couple of examples. In heart failure, we can see, pulsatile flow even in the portal vein. In the femoral vein, we can see pulsatile flow with the leg edema because of heart failure. So this is how we see pulsatile flow in heart failure with leg edema. Another case, female 36 with pain lower limb, painful swelling right lower limb. This is suprapubic scan showing, uterus with the thick cervix, irregularly thick and large cervix, suggestive of CA cervix. Multiple para-aortic and iliac nodes causing compression of the iliac vein. However, femoral vein and saphenofemoral junction was normal. Necrotic node is present in inguinal region. Flow is present in the great saphenous vein and leg veins. Multiple necrotic nodes in the inguinal region and soft tissue edema. So basically, deep venous system and venous system is normal, but there is basically lymphatic involvement leading to necrotic veins and soft tissue edema in this case. So this is a non-vascular cause. This is again female with swelling of the both legs, with the foot is normal, dorsum of the foot is normal. In such type of patients have marked thickening of the subcutaneous fat with normally appearing venous system. So these are basically lipedema, abnormal accumulation of the fat primarily involving the lower limbs and predominantly affect the females, and it is bilaterally symmetrical. Causes can be hormonal, familial, genetic, and idiopathic. So we must be well aware of this condition. Another mimicker is post-traumatic swelling. there is large subcutaneous hematoma present in the entire leg and calf region. So it is nothing but a degloving injury leading to accumulation of the hematoma within the subcutaneous plane because of the degloving injury. It is classical or moral level lesion. Venous system was absolutely normal. Another mimicker venous system femoral vein normal augmentation. But on the knee, popliteal fossa, I can see the Becker cyst is collapsed and thick walled, and it is ruptured within the calf muscle plane, leading to entire painful swelling. There is separation of the intermuscular plane, leading to splitting of the medial head of the gastrocnemius and the subcutaneous deep fascia. There is accumulation of the fluid because of the caudal extension or migration or rupture of the Becker cyst, leading to acute, leg syndrome. So the key assessment points are, we have to assess the status of the deep venous system, including evidence of acute or chronic thrombosis, its extension, status of the wall, lumen, and flow insufficiency. Status of saphenofemoral saphenopopliteal junctions, whether they are component or incompetent with their diameter. Extension of reflux in saphenous veins in thigh and leg with diameters. Number, location, and diameter of incompetent perforators. And or any other vein which is showing any side territory or isolated territorial reflex or abnormality or varicosity can also be assessed. And if possible, we must see the proximal and distal points of the entry and exit point of the insufficiency. We try to search that from where which of the segment is involved and which is the exit point from where the insufficiency has begun and where the basically entry point to the deep vein the vein is ending, and in between the varicosity is present. So we must try to see the source of filling of the superficial varicose veins and its entry point in the deep vein if possible, or any evidence of hypoplastic or atretic or absent vein is also be seen and documented. So just to conclude, I would like to say that the venous system of the lower limb comprises superficial, deep, and perforator veins. Thorough knowledge of the venous system anatomy as well as utilization of appropriate technique, protocol, approach are important for optimal imaging and accurate diagnosis. We have to apply all the maneuvers, relevant maneuvers like the compression, augmentation, and Valsalva maneuver for each segment of the vein we will document and see for insufficiency and varicosity and valvular incompetence. Color Doppler is again evaluation is very helpful in diagnosing various venous pathologies, as we have seen a couple of examples, including all the pathologies, most common pathology like thrombosis, post-thrombotic syndromes and insufficiencies, deep and superficial venous insufficiency, and varicose veins with pre-surgical assessment and mapping. So thank you very much all for your kind attention and giving me this opportunity. Thank you. Over to you, Chinmay.
Thank you so much, sir. It was a fabulous and a comprehensive review of the venous system of lower limb. I'm happy to share that again we had more than 500 participants today from all the corners of the world. It was just amazing, and we have more than 40 questions in the Q&A section. Oh. I will try and filter them as much as I know, but yes. I'll just put them across one by one, sir. The first question by VK is, what is the difference? How do you differentiate between fenestrated vein and a partial thrombosis?
How do we difference between
fenestrated vein versus partial thrombosis? Fenestrated vein.
What does it mean, fenestrated vein?
I think I'll ask if VK is around. Can you just please clarify in the next question. Yeah, I'll take that later, sir. The next is, do perforator veins have walls?
Perforator vein, every vein has got valve, but lacking in muscle layer. They are very thin, imperceptible walls, so they are very much compressible.
So this question was by Henry Zong, who's asking, even perforator veins have walls, right? Perforator is also.
Yeah.
Okay. Thank you, sir. The next question is for SFJ competency to check, do we put the spectral Doppler before the valve or after the valve in GSV at the saphenofemoral junction?
Yes, it is very important. Basically, the GSV receives tributaries in the groin area, and then ultimately dip to join the femoral vein through a terminal valve. And from terminal to, so we must put the cursor basically just after the terminal valve to see the incompetence. First, we see on B mode what is the status of this valve, whether it is competent or not. Then on color Doppler, is there any significant time duration reflex on color? And then we assess it on, when it is competent enough on color, then there is no need of spectral wave form analysis, but still we can always proceed as per protocol. We see on B mode, then apply color, then see apply pulse wave Doppler and see all. Sometime what happens basically, it is the proximal valve of the great saphenous vein which is competent, as we have seen in one case, and the reflex is going to its tributaries of the groin, maybe in the superficial inferior epigastric or circumflex or in the pudendal, causing varix there. So it is always it is always better to put we will put the cursor just proximal to the terminal valve. And sometime in very rarity, terminal valve is also lacking, and it is the last intravenous valve of the GSV, serves as a terminal valve for the GSV, and sometime the other tributaries can join just distal to it. So I have seen a couple of cases where the terminal valve is lacking. So to see GSV insufficiency, then the terminal valve is basically the distal most intravenous valve. Then we have to re-examine this. We have to examine this valve, and along with the tributaries also. So this is how we do check of the competency of the saphenofemoral junction.
Thank you, sir.
Right?
Yes, thank you. The next is there a normal size for a GSV?
Basically, it should be less than 5 millimeter. If it is 5 millimeter or more than 5 millimeter, it is suggested to be abnormal.
Okay.
Otherwise, every vein has got anatomical variations. So the abnormal dilatation is indicative of venous insufficiency. So it is always better to compare with the contralateral side of the limb. What is the status of that particular vein?
And for the perforators, is there any size?
It should be less than 2 millimeters.
Okay, thank you, sir. Rad Doc is asking, why is normal venous flow below the baseline?
Pardon?
Why is normal venous flow below the baseline? Oh.
It is a normal integrate flow which is below the baseline because it is going away from the probe, I think. This is the...
Okay, sir. Are there any normal values of velocity in the common femoral vein and the femoral veins? This question is
basically we don't focus on velocities. Velocity becomes only important when there is atretic vein, and then we have to see the status for prior to the surgical mapping. So velocity, I don't think we don't focus on velocities. We just see the measure in the modified terms and descriptors.
Okay, thank you, sir. Should we include the venous arches in the foot in our report?
Depending upon the clinical situation of the patient. Sometimes you may see the incompetency is more in the leg region, no below the knee joint, and sometimes you will see multiple varicosities around the ankle area. Then the all the perforators in the dorsal foot, dorsal arch and dorsal veins, along with the deep veins, is become important. Sometimes they are incompetent. So depending upon the clinical situation of the patient, we have to extend and tailor and then assess our examination. Right?
Yeah, thank you, sir. How do you ask the patient for Valsalva maneuver? Uh,
Basically, hello.
yes, what do you ask the patient to do?
So we ask the patient to bear down in our own languages in which he understands. Basically, we want to basically ask the patient to have inspiration and then hold it and then apply or bear down to increase the intra-abdominal pressure and try to hold it for a couple of seconds. He or she can.
Okay, thank you, sir. Um, the next is, how do you report? This is by Dr. Devesh Malik, who's asking what to report when there is a dilated perforator but no demonstrable reflux.
You just mentioned it is dilated, no demonstrable reflex is saying. That's it. Whatever you see, you have to mention it. But it is very unlikely that perforator is dilated and incompetent. It is somewhere you are lacking in appropriate maneuver to elicit it. Otherwise, abnormally dilated perforator indicates venous insufficiency.
Okay. If the valve is incompetent, the reflux is present for how long time? Is like a time that the reflux has to be there?
Any reflex which is more than 0.5 second is suggested to be abnormal. This is basically what this is what any reflux which is more than 0.5 second is abnormal. It can be up to 1 second, 2 second, 3 second, 4 second, depending upon the severity and abnormality of the valve, mild, moderate, severe, or gross incompetence. So it depends on the upstream and lower, intravenous valvular status. If the immediate proximal or just we can see just suppose we are examining the great saphenous vein in upper thigh and we are eliciting insufficiency or reflux in it, and if suppose the vein intravenous valve of the lower thigh in GSV is competent, so the reflux will not be of that much duration. But if any abnormal territory, draining territory is incompetent, the blood will rush to that and the reflux will be more of duration. So it all depends on what is the basically the territorial involvement is there. Right?
Oh, thank you, sir. This question is by Bethlehem White. How are Valsalva and augmentation different?
Basically, Valsalva is we are asking the patient to bear down and try to increase the intra-abdominal pressure to basically to see to stop the venous flow in the abdomen. And if the flow is spontaneously coming, then the veins will distend for fraction of seconds. And if the intravenous valves are incompetent, then it will flow back it will reflux and go back, which can be reflected on the color and spectral doppler. Number one. So this is how Valsalva is important. In cases of popliteal vein incompetence, when Valsalva is not that much effective, I basically elicit reflux in popliteal vein or some calf veins, deep veins, by making pressure on the thigh sometime. Because we have to increase the pressure, muscular pressure proximal to our examination by manual compression of the thigh or by asking the patient to bear down or perform Valsalva. This both can work. Sometimes Valsalva cannot work for popliteal veins. So I personally use thigh compression to elicit, reflex. And in augmentation, so Valsalva basically at that shows proximal, the status of the lumen proximal to the examination. We are examining femoral vein and we are asking the patient to perform Valsalva. If it is effective, means the proximal territory is in normal, the iliac and IVC normal. And in the similar way, when we are augmenting, making augmentation by distal calf compression, and we see augmentation means the distal territory, from examination to the lower territory is competent. So the blood flow gush is seen. If it is abnormal, then there will be no augmentation. So both are very important. And sometime in augmentation, what we can see in insufficiency, for example, in popliteal venous insufficiency, when we augment, there is gush of the flow in the popliteal vein forward. When we release it, there is reversal of the flow if it is incompetent. So it works in both the way. It augments the flow and it also reverses the flow. When the pressure is released, there is gush of the flow back if the territory is incompetent. Right?
Yes, sir. Thank you. I believe you do the venous Doppler for insufficiency in standing position, right, sir?
As and when necessary, it is important. Sometimes the patient is having subclinical or very subtle findings, trivial exam. It is important to examine any case of insufficiency in standing position, particularly. It is very important. And if everything is evident and grossly positive on sitting position by just performing Valsalva, it's all right. Or just
okay, thank you, sir. How do you decide which is the entry and exit point in varicosities? Can it be bidirectional flow? This question is by Dr. Ramesh Agarwal.
See, it is important to see the saphenous vein. Superficial system involves two important systems, two important veins. There is a small saphenous vein and great saphenous vein. So it is important to see these common perforators, saphenofemoral junction and saphenopopliteal junctions. So let me know what was the question.
Entry point and exit point.
Entry point and exit point. Right. I have shown through example in my thigh varicosity case. That was a classical and simple examination of entry and exit point. The great saphenous, the saphenofemoral junction was incompetent, but the great saphenous vein, after receiving its tributary anterior communicating branch, was competent. So I can say great saphenous was competent. So here the reflex is going to the anterior accessory vein. So this is the exit point. Because just after the saphenofemoral junction, the upper great saphenous is competent. Then where the blood is going? It is going any of the tributary. It can go anywhere. It can go into the pudendal to cause pudendal varicosities. It can go to anterior accessory saphenous vein to cause anterior thigh varicosities. It can go to posterior communicating posterior accessories great saphenous vein to cause posterior thigh varicosities. So it is the exit point where the reflex is going and making or the anterior accessory vein is incompetent. Now it and its all tributaries are showing varicosities. Now the proximal or the you can call it a distal limit of the insufficiency should be assessed by entry point. So in that particular case, one important channel was draining into the great saphenous vein just above the knee joint. That was the entry. That was the entry point. So here the blood is again coming back and going again to the main great saphenous vein, going cephalad to the through the great saphenous vein up to the saphenofemoral junction in the normal situations, physiology situations. But when the patient is standing, again these develops. So this is how we try to. Exit point is the major perforator, either it is saphenofemoral junction or saphenopopliteal junction. Entry point depends upon the branch which is affected, right?
Thank you, sir. Is there any grading for reflux?
I don't find any grading in the literature. It is mild, moderate, or gross. We can mention just.
And if the saphenopopliteal junction is not visualized, then do you mention high insertion of SSV or anything else?
Saphenofemoral junction is almost always visualized.
No, saphenopopliteal, sir. Sorry.
Saphenopopliteal, yes. There are a lot of anatomical variations. So try to search meticulously with no pressure on short saphenous vein because it is quite superficial. When you put subtle pressure, it will compress and it will be misleading that there is no vein. Most of the time it is very small caliber, most of the time it is atretic, or most of the time it is showing normal saphenopopliteal junction, or sometime it is high in the posterior thigh, sometime only trivial branch is going to join the popliteal vein, and it is continuous as such as Giacometti vein to join great saphenous vein in upper medial thigh. So anatomical variations are quite common and more in short saphenous vein and SPJ. So whatever we see, we should mention.
Okay, thank you, sir. Is there any significance of the CEAP classification in varicose veins? Should we mention it in a report?
Depending upon what your consultant wants, what is your basically hospital setup, what your vascular surgeon wants. So everything is specific for specific institute. So one has to mention whatever is being asked by the vascular surgeon. If they want this sort of reporting and grading system, you have to follow that, right?
Yes, sir. Thank you. I'll take the last question because we are running out of time.
Okay.
So the last question is, where does a vein of Giacometti drain?
Basically, it is a continuation of short saphenous vein in the posteromedial thigh, and sometimes it communicate with the posterior accessories great saphenous vein, or sometimes it can directly drain into the great saphenous vein. So evaluation of vein of Giacometti becomes very important when varicosities are medial thigh varicosities are there. So sometimes the reflex is like we have seen example of anterior accessory vein. Sometimes we see vein of Giacometti which is incompetent and forming lower medial thigh perforators. It becomes very important.
Okay, thank you, sir. I think I'll just take the one more question. Sometimes you see dilated medial gastrocnemius vein that goes superficial and forms varicosities. Is this kind of perforator to be considered? That's where Dr. Jignesh Modi.
Listen, if it is, most of the time we see gastrocnemius veins are quite prominent when we examine the patient in standing position. So these are very often, and in cases of deep venous insufficiency in particular, these all calf veins are very much dilated because of the hydrostatic pressure, because all the deep venous system is incompetent. So when the patient used to in standing position, there are always in deep venous insufficiency, these calf veins are always dilated. As far as any perforator, the upper medial leg perforator, which basically dilated and joining the gastrocnemius vein to the great saphenous vein or and posterior arch vein, then it is considered a perforator, definitely, because it is draining the superficial territory to the muscular territory, and if it is incompetent, the gastrocnemius venous pressure will go through this incompetent valve to the leg and can form varicose veins. This can be the etiology. So it is to be taken care and mentioned, right?
Yes, sir. Thank you so much. I'm sorry to the participants. I couldn't take all the questions. There were more than 75 due to lack of time. But Taylor, sir, it has been wonderful over the last month and a half that we had three sessions. All of them were blockbuster sessions with more than 500 participants in each of them from 42 countries, to be precise. And they just loved the talks, and it was just fabulous. We love to have you on this platform in future.